great, sir. Great video and innovative way it is presented. You all look like heroes. Now we are doing it on the PVR cinemas also, live, big.
I know.
So all the people enjoy it.
Congratulations,
And we are,
Srinivas. Congratulations.
thank,
Those were the.
thanks for joining, sir. With me, I have Dr. Ajit Mulasari, sir, and Ravindra Rao is just joining.
Okay.
And we have Sai Satish, and we have Rajpal, and Vivek Kumar, others to moderate the case on this side, sir.
And
over to you, sir. For
thank
the
you,
case.
thank you, thank you, Srinivas. And clearly, it's a pleasure to transmit to the TCT Asia Pacific. It's indeed a pleasure to be with my colleagues. In my right, as you see, Dr. Vijay Kumar, Dr. Vishal Rastogi, you all know Dr. Manish, Dr. Prateek, and of course we have our anesthetists with us. I must thank them for being with us in this live case, as well as Vinay Sharma, our head of structural echocardiography, and of course all the team of nurses. So that was a great case which I just we overheard. We couldn't see that from Ganesh Manoran, and it's a very difficult act to follow. I mean, I wish I wasn't transmitting a case, because at the end I would have sat there and listened to a tremendous case, and his discussions are paramount. Of course, he's our mentor, so it's a very hard act for me and my colleagues to follow after that case. But anyway, we're going to demonstrate to you another TAVI case, and I therefore hand it over to my colleague Dr. Vijay Kumar, who's the Chief Coordinator of the Structural Program, to tell you about this case.
Good evening, everybody, and we are going to show today a TAVR on a type 0 bicuspid valve, and specially demonstrating cuspal overview technique. Normally, cuspal overview technique is friendly for the tricuspid valve, and it is a routine practice, but it can still be used and applied in a case of Siever's type 0 bicuspid aortic valve stenosis procedures also. So coming to the case summary, we have a 68 years gentleman who had dyspnea which worsened from class 2 to class 3 in 6 months time, and severe aortic stenosis was diagnosed by his local cardiologist, who advised him for aortic valve replacement. He had no other risk factors. Clearly he falls in the low risk category for surgical aortic valve replacement. He is 68, but he had also severe spine issues, so he was very clear that he doesn't want a open surgical heart valve replacement. So he came to us for a transcatheter aortic valve replacement. Next slide. Now, in the era of this low risk trials showing such favorable data, and also with the bicuspid valve registries, we are very much excited to go ahead with TAVR in bicuspid aortic valve patients. But the most important thing is, in these young patients who are low risk, we have to focus that the valve that we choose should have the best hemodynamics, should have the least patient prosthesis mismatch, and of course the newer frontiers of durability is very important, because these have a long life ahead and they can't afford to have valves which will degenerate. And thirdly, future coronary access is important, because they can come for interventions. Next.
So we'll hurry up.
And the valve should be definitely having a we have chosen a 26 millimeter Evolute Pro.
Let's first go to the measurements, please.
And coming to the, and this is of course,
let's get that out. Yeah.
So we can see a preserved LV systolic function, a concentric LVH, and eccentrically opening aortic cusps, and a mean pressure gradient of 82 with a valve area of 0.4. Now, the most important data that we need to analyze for choosing the valve size is the aortic annulus diameter, which is the perimeter is 69.3 millimeters
at the annulus,
annular level.
Yeah.
And at ICD, the intercommissural distance is 23.2 millimeters, and as we go up 5 millimeters and 8 millimeters, it is nearly the same. So it is more like a tubular structure, tubular anatomy, and if we strictly see the ICD distance, then it is mildly flared. So in this situation, we always choose the annular
Go
size,
back to the previous slide, please.
annular size as the basis to decide the size of the valve, and we have chosen a 26 millimeter Evolute Pro valve, which will be 17% oversized, and there's no major aortopathy.
So I will just
junctions
add
are
to
fine.
that so that the questions can get answered for the future. Because we have 30 minutes and we would like to proceed also faster, I would just say that if annulus was a borderline situation between, say, 26 and 29, we'd then look at ICD. But luckily here it's a tube. That's what practically 50 to 60% of our valves are. And therefore, this is fine to actually size it to the annulus plane, as we've done in this case with a 26 millimeter evolute. And Pro obviously is an advantage in both this bicuspid valve anatomy, as well as the ability to therefore decrease the incidence of paravalvular leaks. Go ahead. I want Vijay to tell you very briefly around, you know, how
The
do we
next
actually, you
slide.
know, after all, there are two cusps, and then we're talking about cuspal overlap. So what do we really mean by cuspal overlap in a bicuspid anatomy? And so, Vijay, would you just tell them very briefly around that?
So I would say that cuspal overlap needs actually on the three-Mencio 3 points to be constructed to have a virtual annular plane, and then the S curve is determined to have the cuspal angle in which the right and left cusps are clearly overlapping and the non-coronary cusp is segregated. But in case of bicuspid aortic valve, also type 0 specifically, we can create a similar 3-point structure. And in that, what we do is that we take the red point below the lowest point of the left coronary artery origin, and then on the opposite cusp, we divide it by 2 perpendicular lines into 2 halves, and then at 45 degrees, we put 2 dots. So basically, then we get on the other side of the cusp, on other cusp opposite to the left coronary side, we divide it and we put 2 points, and then we have 3 points that constructs a virtual annular plane in case of bicuspid valves also.
We'll discuss why this is an advantage.
And then we derive the S curve,
Yeah.
where in this case we have the cuspal overlap view as RO 12 and caudal 23. The advantage of cuspal.
We'll discuss the advantages, because I think we'll have gaps in between where we will talk to you about this. But at the moment, you see that the coronary heights are great. There's no problem with that. You just, apart from the aortic arch where you see an angulation at the upper curve, the rest is not a horizontal. But what is true is that what we've done in the meantime, so it's very clear, we've got a 26 millimeter valve, we've got femoral access out here, we've got a 16 French sheath on this side, we've got the pigtail and the pacing wire from the other side. Can we just go on? And yes, we always do it as a bullseye puncher, as you will just see. We find that as extremely, extremely good. You will just see the bullseye puncher. Can we just move?
Next.
Can we just move? Next. Instead of talking. Next.
Next.
So, yeah, and then we just puncture that bullseye. Next. Nothing more here to show you. There were 2 other steps that we wanted to show you. Could we just move? And by the way, flush every of these, please.
Next.
I don't see pressures on this, yeah? Okay. And next. So
Bicuspid aortic valve, sir, is your strategy to predilate?
absolutely, absolutely, and we'll just come to that. So just wanted to show you that this is the cuspal overlap view. The cuspal overlap view advantage in a bicuspid is that it's more predictable. It's more aligned both to the catheter as well as to the cusp. And by the way, the membranous septum lies right in the center because it bisects the posterior non-coronary cusp from the right coronary cusp, even though that this is a bicuspid valve. So right in the center of this lies the membranous septum, and that's why we've started more aligned, should we say, and more parallax removed in this view, even in bicuspid. So we go to the next, and we'll just show you real life crossing of the valve itself. Next. So that I think we are now very clear. This is real life crossing of the valve. As you can see, I think we normally do take a minute across, and I mean I have taken on a live case 15 minutes to cross the valve, and then 5 minutes to deploy the valve. I was hoping that would not be the case in this patient, because he has severe bicuspid aortic stenosis where unfortunately it can actually take some time to cross. We're actually seeing real live images. It's now 30 seconds, and there we are across. So once we did that, we of course positioned it. And again, another thing they wanted to show you, which is very important for all. The wire is drawn in, it's a straight wire. My Amplatz diagnostic is sitting in it next. And then while waiting for you, obviously, we would just change this to a pigtail catheter and wait with view. We would never actually sit with a confida or any other stiff wire inside the left ventricular cavity. Next, so we now got what we got, a J wire in, and then we get a pigtail in. Next, and we got a pigtail in, and we push it to the apex, and we say, okay. But you must always be sure of your pigtail. Can you go back? I wasn't happy with the pigtail where it was lying, and you can actually see that it's actually going there. This is the real. So I pulled it back, and I pulled it back to the extent where pigtail would start opening up, which means that I've actually got it entangled in one of the papillary muscles. And here, as it comes back, I push the wire in, and you'll see that. And it's so important to be in the right position. Recognize your pigtail, that it's not at the, it may look at the apex, but it's away from the inferior surface, then you're actually in the wrong place. So this was what we did in this time. Go on to the next point. So I think we are now here. This is where we are. Let's look at the gradients.
Another important point, what you mentioned regarding the pigtail and not leaving the wire, apart from the injury to LV, is you could also get artificial ARs, and patient could get into low output state when you have a stiff wire across the aortic valve.
Excellent comment. And you see the gradient across. The gradient is more than a, yeah, it's close to a 120.
We also have Dr. Grube with us here, sir, and Dr. Ravinder Rao just logged in, sir.
Excellent. They're all great experts, and so it's going to be wonderful to actually interact with them during this case. So we have a 20 millimeter gradient, 120. And so I think that we're ready to go ahead. You can keep asking questions. Me or my colleague would answer that. Because we have only half an hour, let's actually now get our confida wire. And we would predilate with a 20 millimeter balloon prior to the valve implantation. We've already checked the valve. It's a very important habit that before you start your case, once your wire is across, check the valve, because from there on, you're committed to doing the case. So here we are on the fluoro. You can see that our wire is now nicely sitting at the apex. It's very important that we do that and then bring this nicely back. And we've delivered our confida in one smooth motion. We'll actually keep it positioned towards the apex. You saw that was a hypertrophic LV. And therefore, now we're going to do with a go ahead with the 20 millimeter balloon and a good nice dilatation. So you can keep commenting, you can keep asking questions. We will continue to answer them.
Dr. Ravinder, any comments? Can you make him came?
So we now have the 20 millimeter balloon.
Dr.
Okay.
Grube, sir, you have demonstrated excellently, and fortunate to have you again during this case. Any comments, sir is asking?
In fact, we would continue to learn from their experiences rather than.
Yes, sir.
And you see how tight this is. This is really calcific. So I'm actually across, and we'll soon dilate this valve. Let's go to the earlier projection. I think that will be very good to see this valve in a complete.
So we are
view.
doing 1 millimeter
right.
minus. The size of the balloon is 20 into
Okay.
40.
So we pace at 180. Yeah, the pressures are down. Okay. Deflate. Stop pacing. So you saw that. That was huge calcium. What did you think of that?
Yeah, sir. I think as a strategy, you would make the valve also ready, because sometimes when you dilate, it could be significant AR, and it should be ready to go.
So the valve is ready, as you saw, very early on. That's what I'd emphasized just a bit time ago, that the moment you actually get your wire across, your valve should be ready, because then you're committed to your valvuloplasty. So the valve's been ready and checked, and we got certainly an increase in pressures. You can see that very nicely. And now the systolic pressure has moved up a bit, which is good. And so let's go to the valve implantation.
Dr. Grube, sir, you are always saying to avoid balloon dilatations before, but in bicuspid, I think you more often need it. What are your thoughts?
Yeah, as I said before, heavy calcium load and bicuspid, I do it, but mainly because I would like to see because of the insecurity of sizing, you know, you have an idea on how to
हाँ जी।
undersize. Sorry, I don't
बहुत
want to
बढ़िया
interrupt
चल रहा है।
Ashok.
बहुत अच्छा चल रहा है।
So probably you will undersize it and don't take too much bigger balloons to avoid AR.
Yeah.
At the same time,
Yeah.
length of the balloon also we need to be careful. I think if you have too shorter balloon, it tends to slip. If you have too longer balloon, sometimes LVOTs could be having problem. I think how they
Yes.
selected correct size balloon taking is important.
But I admit this is not supported by any data, it's just experience.
Okay.
And I don't like to
Sir?
oversize it by
Clean this
cuspid
with
valves.
you not concentrating on the whole of the wire. Beta ring.
And do you recommend taking aortic root injection when you're inflating the balloon so as to see how is the other places?
Exactly. Exactly. The amount of leak, if you have a leak, the amount of leak and the size of leak. So, because honestly, I don't, well, I know that the ceiling in bicuspid is not
Don't drop
the
that
annulus.
into the
The
saline.
ceiling
Please
is
don't
in the
drop it into the
leaflets,
saline.
and therefore I'm questioning the relevance of annular-based sizings, you know?
Now move that away, move the tray away, Vijay. Right to the end, clean it right to the end, and then saline. Clean it to saline. Use it. Okay, we're now going to put the valve in.
Sorry, Ashok, what valve are you putting in?
So we 26 millimeter Evolute Pro. You saw that
Oh,
the
I thought you put
parameters.
my valve in.
No.
No,
I think-
seriously.
no, you know, we've got a spectrum of cases, as you know, with my valve, in bicuspid anatomy. But I think here
Because-
was a very calcific one. I think this actually deserves a pro. You can see, and then there's by the way, you see the outflow tract calcification.
Yeah, right.
And you see
No,
that.
I agree with you. I just dropped into the case,
I
but
know.
I just
Okay,
I
Vijay,
tell
you are.
you. But I tell you, my valve
Vijay.
is gaining a lot of traction here.
So sorry, the wire came out. A bit of a
Yeah,
lack of coordination which happened there.
happens in live cases.
Yep.
It happens in live cases. That's what I was about to say.
You're not going to look anywhere else apart from that.
Ashok, I miss you guys.
That's right. I miss you too.
Man, oh man.
Miss you too. Huh?
Recrossing?
Yeah, so we are again going to show you recrossing.
And Dr. Srinivas, I thank you very much for responding so promptly. It was very kind of you.
Just take everything out.
No, we should be thanking you so much, sir, in spite
No,
of
no.
all your tough schedules.
No.
And
The gratitude
time.
is with me. The gratitude is with me.
Thank you, sir. And, I mentioned actually in the end of your case, seeing your goggles and spectacles, I feel you look like a hero, and the PVR Cinemas big screen, you are looking like that. Thanks for joining, sir. Sir,
Okay. So
there's no
sorry
need to
about
rush,
that.
sir, because we have a case lecture only of Dr. Grube, sir. If you want us to
Oh yeah.
finish lecture and come back to you again
No,
after
no.
this, we can do
I-
that, or we want to stay with you, we will do
I
it.
think we once we cross, then we just ready to deliver the valve, isn't it?
No problem.
Yeah.
And
Whatever
let's,
it is.
let's hope the crossing is faster than last time. You saw me 30 seconds. Now
You
you'll
know-
see a much longer time frame.
You remember, Ashok,
Yeah.
you know, it's a boring thing crossing with the wire, but sometimes in life cases, it's tiring.
Yeah. So last time, there it is. Okay, Ariel.
There you go.
Ariel. Okay, so it was 25 seconds this time. So that's not so bad.
That's also an important step, sir. For the sake of everybody, I'm just commenting. Once you cross,
Yeah.
it's also important to change to RAO and
think
see
you've
to
lost
what
your
extent you've
concentration.
gone and whether it is in the carde and things like
Relax.
that to place the wire well so that you can. If
It's
you have
always,
any doubt,
I mean, that is so much important. I mean, here again, we may be through a Cordy, but no, we're
Yeah.
not. Look at that. This is the curve that you actually want.
Right.
and if you have any doubt, you always put a pigtail and position the
I
pigtail
always do
properly
that,
and
by
then
the
take
way.
the stiff up.
That is one shortcut I don't take. I've multiple times also positioned it through the amplats, but because the amplats could have gone through the first wire, straight wire could have gone through a Cordy. If the amplat curves upwards nicely, then of course I would position a confida through that. But otherwise, I prefer never take a shortcut, always be absolutely perfect and meticulous. 2 minutes saving is not a saving when you're actually saying that.
You know, Ashok, that's why I still admire you. And despite of all your experience, you never take shortcuts.
Thank you.
No, seriously.
Yeah.
I really mean it. I mean, there are hardly any intervention cardiologist has more experience, but you never take shortcuts because at the end, you might be paying for it.
Yeah. And now again, we're across and we'll soon be in the same position as we were not too long ago. But that's a bit of a comfort that we'll have 5 minutes extra for this time off, should we say.
I feel at home.
Also, Eberhard?
Yes.
Yeah, Ashwin here. I just wanted to make one point is that when
Hey,
you are
man.
hi, how
You're
are you?
getting younger.
Like you.
Oh.
Okay, I think that when you are using an extrafemoral
Sure.
approach like carotid or subclavian, then
So-
crossing
so-
the aortic valve requires a little more different tricks. I think carotid can be easily crossed with the multi-purpose.
Yes.
Okay.
That's my experience, and I think
Yes.
that I think is just worth
So
keeping in
now you
mind.
concentrate on that.
Ashok, you are doing great, Ashok.
Thank you, and we soon be actually now putting the valve in again.
Yeah.
And this time I've actually given Vijay a very stern look. I hope that does it.
Now this Pro goes through 16 French, I
Yeah,
think.
so
no?
I took the
yeah.
16 French sheath. So
Okay.
just put the 16 French sheath out, and now we're going to go in. And of course, you remember that there was this issue right at the top of the curve. We have our strategies around it. So Vijay, look at the wire, and the valve is going in fine. And we're actually going to go with that port at 3 o'clock position. Remember, cusp, we still have to be
For
always
coronary
cognizant.
access, future coronary access.
That's right, absolutely. Let's go, Elio.
While crossing the arch, I think it is always better to go through LAO,
Yes.
not to strip through
Again, the same thing. No shortcuts. We
Yeah.
need to see that arch. We're at 3 o'clock right here, and it's all going to be gentle, no forcing. Okay, so here we're ready to go across that curve. Okay, Vijay, you holding on?
Yeah.
Good. And we're going to see that curve on the top. Show the
Yes.
curve on the top. Good. And see whether that hits anything. No, it doesn't. We're doing very well. And a bit of a tug, but no, don't leave the wire like that. A bit of a tug on the wire, and I stop here. Come to the cuspal overlap view, because you see you don't want to go in and come back. At the same time, we will also reposition it. But the reason for getting to the cuspal overlap view is that you want to stay exactly above the cusp and let everything go. And now I'm going to, as you can see, that my pigtail will actually be interacting, and therefore the good part is that we have this shadow of calcification which exactly tells us where that cusp is. Okay, and here it
And you can also push the pigtail to lowermost point. That should be lowermost.
That's
And
right. And
you
actually
don't
it is
you don't believe in implanter's view seeing at all, sir. Directly go to RAO view.
absolutely, and you will see how it actually helps us in a tremendous manner. Can I have a wire? And I will just let that go. See, all the time also look at pressures, that you're not causing AI, that you're not causing hypertension, because if you are, then you're not going to faff around too much. But at the moment we're doing fine, and I'll position the pigtail so that we actually have the best position of the pigtail, and that's the best position of the pigtail. And so can we have a flush? Yeah, good. And we are connected. Okay. The reason for getting this sorted out right now is that when we come in, I just firstly, of course, I would go in, because remember, now I will come back now and then again go in. Firstly, it was a bicuspid valve, we've dilated it, but I will go in, and that's where I would position it. I hope you've understood what I've done. I don't want to pull it and then start releasing it. I want it to be pushed and releasing it. The second thing I always look at is that my wire is at the apex and I'm half at the pigtail. This is my cuspal overlap. Now in this you see that automatically my parallax is removed on that band. What that tells us is that we align to the valve and we align to the plane, annular plane, and our valve is also aligned. With that, I think we're ready to certainly release, firstly up to the third node, position it, and then move ahead. So we are in the cuspal overlap view?
Yes.
Okay, automatically band is aligned. So let's start releasing it, Vijay.
Pacing, sir?
No, not at this time. Till the third node, the valve is not flaring. So all you're doing is making sure that your wire is at the apex, making sure that you're at the pigtail, letting the valve itself move wherever it wants, and then certainly come to the third node. Yeah, Vijay, a bit more, a bit more, a bit more, a bit more.
Valve moved up a little, sir?
Yeah, no, that is your sheath coming back. Okay, because here I'll give you a,
yeah, sorry.
okay. So that gives you a better shot. Okay, now it's at the second node, and by the third node, I will actually have it at the lower end of the pigtail. There you are. Okay, now I'm ready to settle at the lower end of the pigtail, and after that the mag will, and I'm here it is, I'm actually settling it down. No, don't do anything. This is the place that I'm actually going to start unsheathing the valve, which is also going to be at pacing. So you asked me the pacing. Yes, we pace at 150, and we'll start unsheathing the valve in this. I'm at the lower edge. Let him take a puff. Give me a puff. Yeah, give me a puff. Yeah, you'll have to give me 8 ml, but this is fine. You know that I'm at the lower edge. Okay, so this is now we start pacing. Okay, Vijay. Over to pacing. Firstly, pace at 150. And I want to see the drop in pressures. Stop pacing. I don't see adequate drop in pressures, so I go up to 170. Okay? Yeah, Vijay, go on. Slowly and aram se, and you let the valve go in a bit. Keep going, let the valve go in a bit. Yeah, keep going. Keep going, keep going, keep going, keep going. Keep going. Vijay, faster. Stop pacing. This is our bit more. Come back a bit more, Vijay. So now you can see a bit more. Bas, that's it. So now you have, now this is the time that I've actually got a, I'm not bad. Let me check on the other side. I'd be perhaps 1 or 2. Would you agree with that?
Yes.
Okay, so let's go to the other view. My pressures are good. My diastolic pressures are good. LAO. So now we go to LAO, remove the parallax. Abhi kuch nahi karna, Vinay. And I'm actually going to see where we stand when the parallax is removed. And I think we've got a parallax remove view. And you can see how constrained we are, despite the predilatation. And I think that we are actually too shallow also. But we will just give a puff and actually understand this. So give a puff. You can see that we are shallow. Now this view,
Almost like zero implant.
yeah, and by the way, this view is more meant for the other side. Less for this side, but more meant for the other side. So I'm not happy with this implant. We may be -1, but I think we need to be slightly deeper. And I think we can be. So let's go back to our
view.
and we're going to implant it slightly lower, and that will be my final implant, I hope. Okay.
Capture.
Yeah, so we're going to capture this. Okay. Keep going.
Dr. Grube, in your experience, in our efforts to keep the valve almost very little down, did you have any incidences where valves popped up?
I first of all, I never correct Ashok, as you know, but I would have probably left it. I understand that he thought you were on minus, And bicuspids, I'm not worried about being minus. I think it was for me, it was a great implant.
Yeah,
And
I
it
know,
was-
Eberhard, you are an expert, but
No.
you know, there have been
I think that-
situations,
Yeah.
you know, that the valves have actually at that level, just a bit more, Vijay.
And I agree,
Capture.
Ashok. In case you do have to do something with the balloon, then -1 is not a good thing.
Right. And it seemed as if we were,
Yeah. I know what you mean.
okay, Vijay,
Can I ask what valve size you're using?
are we in that same projection? We are 26 millimeter. Have we captured it completely, Vijay?
Yeah. Captured it completely.
Are you captured completely?
Yeah, completely.
Yeah, okay. Just hold it. Hold the wire. We actually have a problem in trying to, yeah, that's it. Okay. And now again we're going to go forward and then go forward here. Okay. Right, again we're going to uncapture. Release. Go ahead. And this time I'm really going to be nicely and comfortably.
Ashok, are you happy with the wire?
Yeah, I'm happy with the wire. I'm just going to push it forward, but I'm happy with the wire. Go ahead. Keep going.
You're pacing?
No, I'm not pacing at the moment because I'm just going to come back with a release of the valve first to the third node and just stop here, Vijay. I'm going to actually review everything. Okay, good. Keep coming back. Keep coming back. Okay. And this is where now my position this time would be here. Let's stop here. So you see the difference in the position that I'm going to give it this time? Okay. Inject.
10.
Yeah, very, very good. And I'm going to actually be here. Okay, now we're going to pace. Pace at 170. I still won't want it deep. Okay, Vijay, go on. But I'm actually going to be generous, should we say? Not as generous as this, but going to be generous. Yeah, keep going, keep going. Keep going, keep going, keep going, keep going, keep going. And stop pacing. Stop pacing. So this is more generous, should we say? Okay. And now I'm going to just make sure that this thing is back. Let's go to the other view.
I think what we need to take care is at one point when the valve is closed totally, pressure is 0.
Yeah.
So you shouldn't stop there, but once you come to a stage where the valve is open, you get some pressures, then you can take your time and to take injection. That's what sir is doing.
Inject. Inject. So now that I think is a better position.
Yeah.
Okay. At this time, what you've seen me do is two things. Firstly, my wire is no more at the apex. Secondly, my whole catheter is neutral. It's not dragging. Can you show the whole curve? That's right. So I'm more neutral now. And that's, I think, is two very important aspects. You don't want the valve to jump out. You don't want it to dive in. And you are already got your wire down. Now we're going to give it 5 minutes. And that's my normal situation that I actually do. Let this valve expand. You can actually see that heavy calcification. This valve is going to take its 5 minutes. Pressures are good. EDP, our diastolic pressures are great. Our echo, Dr. Sharma is going to check up, our echo specialist is going to check up. And now we can address some of the questions because I think we will implant it in 5 minutes time. We're already at a minute since implantation, so we'll just give it another 4 minutes.
So you always wait for 5 minutes, sir?
Yes. For all these valves, and especially in bicuspid anatomy where it's partially open and it's not fully settled, it's a very good idea. What do you think of that, Eberhard? It's a very good idea to let
I think
the
it's a
valve
very, I'm always learning from you, Ashok. Honestly, no, seriously, I don't do it that way, but I think it makes a lot of sense because the patient is stable.
Yeah.
And after 5 minutes, I will probably wait once it's done, but then it's too late anyway. But I think it's a very good thing. It's excellent.
Yeah. So we'll go
And
to
the positioning is very good.
So we'll go back to that LAO projection now. That same thing, parallax removed. Let's work at the parallax removed view. And can we go a bit cranial? Is this magnified? Yeah, it is, and it's a parallax remove view. So I think we are actually waiting. So the things to address are, how do we release the valve? And actually that's I think is very important. We've got what we all call is a 0-1 position. I think this would be ideal for a bicuspid valve. So we're going to actually release it with this wire right here, as you can see, away from the apex, sitting in the center of the cavity, no backward or forward tension. We would actually keep it neutral, perhaps a bit of a forward push, making sure that, and then we pace again at the same rate, 160, 170. Depends upon the patient, of course. You drop your pressures down to less than 100. Keep it very still, keep it absolutely slow. Make sure that the valve does not move at all, and just gently deliver it, even if it takes you 30, 40 seconds to deliver the valve, just do that. And that is how we would actually go about delivering this valve. We're also seeing that it's going to expand further, Bharat. As we go the 5 minutes, that is going to continue to expand further, and I think you can get the sense of that. That is certainly getting that image to expand further. So that I think is an important aspect. You can see that the thick. In the presentation, did you see the fact that we actually had this chunky calcification going down from the into the LV outflow tract? Another reason why we didn't want to use a balloon expandable. But on the other hand, we always prefer the self-expandable Evolute Pro platform because of the low gradients is supra-annular.
Yeah.
And the fact that you actually do justice to the patient, both in terms of patient prosthetic mismatch and durability as well, in these what we call theoretically low-risk surgical patients.
Yeah.
Now we are actually at 4 minutes, so if you don't want me to take the shortcut, and if you're okay with that, I think you would like to see the valve implantation and gradient. I don't want to push your time frames, but if you just give me that 5-7 minutes.
I think it's very, very interesting. Very well done.
Then we would be far more, at ease and don't want to rush through anything at all. Once you create your, and I would urge this for everybody, once you create your own principles of functioning and say there are no shortcuts, if you create your own systems and you say this is my process of doing it, then for no reason should you ever actually say, well, let me just do this and take a shortcut. I mean, that's what I always believe. It always helps the final results for the patient, and I think it's, then you don't have to look backwards and say, I wish I'd done that and I wish I hadn't done this, and so on. And so forth.
But if you are taking a expandable system, balloon expandable valve, this is not possible. No, what do you thought?
Yeah, no, in a balloon expandable, it's just bump, and that's it, deflate, and it's there. But in a self-expandable nitinol platform, you're giving it time to expand, and you're giving it time to get rigid and rigid and rigid. In fact, it's settling down into the annulus, and you then have more expansion and less chance of creating any issues. So here is why now we decided that we're going to deliver it. We are actually fine. We're at a minute, 5 minutes. So, okay. So Vijay, we're going to actually deliver this now. Okay, very slowly and gently. And you go on to pacing. You pace at 170. We're going to deliver it. Okay.
And you do a slight forward push, right?
Yes, that's right. Slide forward. You saw that. You noticed what I was doing. Yeah, absolutely. Pace, and Vijay, you deliver it. Pace at 160, 170. Yeah, go on, Vijay. Slowly and slowly. I've got a slide forward push. Yeah, go on. Slowly. I love that. I think it stopped pacing.
Both the hooks are out.
So both, yeah. Yeah.
Now it's good.
So that's out. But I think the next point is equally important, and I must emphasize that. We don't want any of this catheter to come anywhere close to that.
Nose cone, while getting back the nose cone, you should be careful so that it doesn't interfere with the valve. That's what you're
Absolutely. So I'm actually practically, as you saw, no, I'm purposely taking the wire out so that I don't have any nose cone mishap.
Even Dr. Ganesh was mentioning, sir, that Abbott system also has more wider
Absolutely.
cells at the base.
Come,
so
Mario.
It's all the more important to take carefully out.
Come, Mario, and we're going to look at it in every view. That's good. So let's go to LAO projection. It's expanded in this view, and you know, you can see that it's not expanded in this view. LAO, go LAO and go the cranial. And that's an important aspect. Look at the way it's unexpanded. You see that? And that's one of the reasons why I have to be very, very careful with the nose cone. And if I can't get the nose cone out safely, I'll have to put another wire on its side and just balloon dilate this further. So let's see if I can get the nose cone out without any situations developing.
Very, very important steps, Ashok.
Yeah.
Very important steps. Changing of the imaging intensifier, the planes.
I remember Eberhard showing one case before. At
See
one,
that,
view, in,
Eberhard?
one view it was expanding
Eberhard?
quite well. Other RAO it looked totally underexpanded.
Eberhard,
Yeah.
did you see that?
Shown one case.
I did.
Very important to demonstrate how you should not
Take it.
force your nose cone out through that narrow path. And I think this shows you extremely well that you take your wire out as much as possible, change the alignment, and then take it
Beautiful.
out. Okay. Eberhard, I think that we will measure the gradients, but I think that we will need a post-dilatation. So Vijay, I'm taking everything out. Give me a 16 French sheath. Make sure that you just concentrate on your wire.
Sir, we are worried that we have already exceeded by 15 minutes. We'll have Eberhard's talk, sir, and you can dilate and
No,
then
it's no
manage
problem.
the-
No problem. I have all the time in the world. If you have it, that's fine.
Vijay, you didn't do this, but anyway, go ahead. Take it out. Okay.
Fluoro दिखाइए.
Yeah, I'm holding the wire, not to worry. In fact,
Normally, I think it is better to check the pressure before we decide to post dilate, sir.
I will do
Yeah.
that for you so that it's all systematic and interesting, though it obviously appears that looking at this, that you would be clear that it has to be post-dilated, but at least we should do that.
At that calcium point, it looks like it is being pressed on one side of the
Absolutely,
calcium.
absolutely. So we're going to put the pigtail in, we're going to measure the gradient, we're actually going to look for the AI and do the needful. Okay, so can we have, Vijay, can we just take this out? Without taking the wire out, please. Okay, pigtail. Yeah, we'll do that later, pigtail. And come to the RA projections because we're going to see what we can. So far so good till now.
Yeah.
Look at how nicely dilated it is in this view. Go to caudal, it's great. Go to LAO, it's bad. Okay. Flush on. And let's see the gradients and everything else. Flush both. So we have at least a,
22.
and give me the pacing wire so that we can actually have this, sorry, give me the,
Can you show the hemodynamic screen, not
so-
the groin?
show the hemodynamics, please.
ये
Give me the J wire to bring this back. Bring this back.
How much is
flush
the
on,
gradient,
Flush
sir?
on, flush on. I'll show you the gradient. Here,
इसको दिखाओ.
while there's no AI, the gradient is around 30 millimeters, around 35 millimeters. You see that?
Yeah.
Yes, yes.
RAO projection, the EDP is good. And so certainly this requires, so what's the post dilatation? What's the size?
22.
Give me the confeeder, please. So get me a 22 millimeter balloon. Okay. Confeeder goes in. And okay, let's go to the LAO projection, which actually showed us everything the best. And this is where I've got to be very, very careful. This has got to be pacing at 200. I've got to be low. I just have to make sure that we're very good at it. And therefore, let's have the balloon. So
What size balloon you're taking, sir?
22. And so we will just do that. And I know that Eberhard's been kind to us because and of course, it is interesting. These are the real life steps at the end of the day.
Very, very good and very important.
Okay, holding? Okay, and Vijay, you holding that?
Yes.
Yeah. And I would actually now position my balloon a bit inside so that we are actually good. Okay. And I'll tell you when to do it, because see here, you cannot make a mistake. It'll be rapid pacing. I'll see the pressures come down. He will inflate. He will deflate. I still won't stop pacing. I will make sure that my balloon is fully deflated before I stop. Okay. So let's pace.
All the steps are important for a valve not to pop out.
So let's pace at 200. No, Vijay?
No, I'll not do it.
It's coming down now. Okay, go up. Deflate. Stop pacing. You saw that? We've opened the valve up.
Yeah, now it has come into the calcium. It was slightly inside.
And you can also see that look at the way it's open now. Okay?
Excellent.
So Vijay, this has to come off. And we'll just show you the final gradient, because that's what matters at the end of the day. You can see that there's no AI. The diastolic pressures are great. The valve is exactly at the point that we wanted it to be, so I've got nothing wrong, nothing.
That's right.
It is at 0. And can we have the pigtail now? And you, Leo?
Hey, Ashok, this is Saurabh. I just logged on.
Yeah. Go, Leo, slightly. Get the parallax out. Yeah. Go cranial. Cranial. Go cranial, more. Bus, good. Okay. So let's see. So Eberhard, if we did find a gradient now, what would you do? Flush on. I hope you haven't.
I think, well, let's see. But I think, to
0.
your point,
Look at that.
Ashok,
I just wanted to see the gradient. Can we show him the gradient, please?
Yeah, that's there showing.
It's 0. Can you see that?
yeah,
EDP is fine. There's
Beautiful.
0 gradient. And let me do a final injection also, so that we've completed our process. And
and to your point, Ashok, -1 would have made a big difference.
suck back. And can you just wait for 30 seconds for our last shot? And push. And let's do a 20 ml contrast.
You take out further picture.
No, that's okay. Okay, we're ready to go. Our final.
Some recoil back.
Okay. 0 leak.
Perfect.
0 gradient, 0 leak. And I
Perfect,
think-
sir.
and I
Thanks for
think it's
excellent demonstration,
it's a
sir, and
zero.
various steps.
0 gradient,
Dr.
0 leak, and 0 position.
Beautiful.
Perfect, sir. I think thanks for an excellent
you.
demonstration. We are joined by Dr. Saurabh Gupta also, sir. He was mentioning, talking to you.
Saurabh
in
is
the
a great
procedure.
friend. Saurabh,
Thank
great
you.
to see you.
Thank you, sir. I think we need to
Ashok, that
break
was
here.
fantastic.
Thank you.
Great
Thank you.
case demonstration.
Thank you very
I
much.
think,
Thank you. Thanks to
we'll-
my colleagues, and thank you all for persisting with us.
Thank you.
Excellent.
Greetings from Fax Foundation. TCT India South Asia 2021. This video brings to you the live case learnings regarding TAVR case demonstrated by Dr. Ashok Seth from Fortis Escort Hospital. This was a low-risk TAVR case in a bicuspid aortic valve patient, and the points which were very well highlighted was regarding the assessment of such bicuspid aortic valves, whether type 0, 1 or 2, on the CT angiogram prior to taking up this patient to the procedure. It is very important for us to assess the annulus size and then probably also measure a few above and below so that we get a fair amount of idea whether the bicuspid aortic valve annulus and the aorta is it tubular cylindrical or pyramid shaped or inverse conical shaped. It's important for us because we place the valve at a slightly annulus or supraannular location in this bicuspid aortic valve anatomies, and probably we need to oversize by 15 to 20%, and he felt that probably self-expanding systems could see better because of supraannular location with lower gradients and better effective orifice areas in this younger low-risk bicuspid aortic valve patients. Other important aspect which Dr. Seth highlighted very well is regarding the cuspal overlap technique. And we were always okay with the cuspal overlap technique in the tricuspid aortic valve, but what we also learned during this live case is even in bicuspid aortic valve, you could mark one point on the non-coronary side, and on the opposite side you could divide it to 2 points and then make an artificial trigone-like and still make an S-shaped line, helping us to follow the cuspal overlap technique even in the bicuspid aortic valve. He stressed this point very well that positioning we should plan for a level 0 or -1 position. This he felt will avoid the AV block. Dr. Sushil was also highlighting that it need not be totally 0, it could be -1, but probably what we need to achieve is not to go too much into the membranous septal portion, which could get into development of complete heart block, especially in such younger individuals and with the self-expanding valve systems. And this patient had a severe heavy calciums, especially towards non-coronary cusp side, and Dr. Seth felt that pre-dilatation is mandatory for such cases, but only word of caution is pre-dilatation should be done with the undersized balloon and probably keeping the annulus diameter, the LVOT diameter in view, and probably keep the balloon size about 4 mm less than that so as to avoid too much of complications, ruptures and severe ARs happening. And during this time it is important for us to prepare the valve before, and then once you dilate it, if a patient develops AR, we should be able to position the valve immediately. Then while during the deployment, he showed about the cuspal overlap technique, how to position the valve in the RAO view, and then also check in the LAO view later, and then see on the both sides how the valve got seated. And after deployment, after the third rumble, when the patient gets back his pressure while deployment release, then his policy is to wait for at least 5 minutes, allow the valve to expand it well and seat it well, and this way he felt it would avoid valve pop-outs and gets itself positioned well. And only word of caution is you should start at 0 position, and he was stressing that always don't allow the valve to deep dive, and then probably you should deploy the valve in 0 position so that it could slightly go to -1 if at all, and then this would help in optimal positioning, especially in bicuspid anatomies with the supraannular placement, and where valve gets holded up at a supraannular level, and this could lead to good results on follow-up. And after deployment, when we checked, it looked okay in the RAO view, but it's always important, we learned that to check in the 360 degrees, and on the LO side, the valve indentation was seen because of calcification, and then that's how we decided. And when the gradients were checked, there was also 30 mm gradient, and then it was decided to post-dilate the valve again with a slightly bigger balloon, but still lesser than the valve diameter. And then after the post-dilatation, with a fast, rapid heart pacing, then the gradients disappeared. And then when checked on the aortic root, there is no AR. So that's how in the final we could achieve zero gradient and zero AR with optimal placement of the valve. And that's how the patient could have good long-term follow-up results. Again, before we close, the most important point which Dr. Seth highlighted was the slow release of the valve and the proper study of the CT before, and probably following the cuspal overlap technique. And then finally you should aim for zero placement of the valve so that you will have zero gradients and zero aortic regurgitation. Hope this live case and the live case learnings, all of you have enjoyed it, and it will help you in practicing such in our country, where we tend to do more and more low risk TAVR cases. Thank you. Yours, Dr. A. Srinivas Kumar.